Hi and welcome. Thank you for joining us for this evening's TED Talk on swallowing exercise science, a topic that is personal to me as a head and neck cancer survivor with severe dysphagia. My name is Ed Stever, and I'm the president of the National Foundation of Swallowing Disorders. Without learning some of these exercises in 2006, specifically the supraphylatic swallow and the effortful swallow, I may very well have been on a feeding tube for the past 16 years. It is clear that this topic is of interest not only to me. Almost 1,600 people registered for this event. For those of you who donated upon your registration, I want to thank you. It is only with the financial support of our community members and sponsors that we are able to provide high quality free events. Before we begin, I want to make a quick announcement to those of you on the call that are head and neck cancer survivors with dysphagia, or to those of you who treat head and neck cancer survivors. Enrollment is currently underway for a phase 2 clinical stem cell trial being conducted out of UC Davis and UCSF. There are travel funds available for those in need. You can scan the QR code here or reach out to us and we can connect you to the trial. The NFOSD actually helped fundraise for this research in 2013 before it was a clinical trial, and we're excited to announce that this project received $11 million in additional grant funding within the last 6 months. So, turning back now to the night's presentation, please note that you will be muted during the presentation. We encourage you to ask questions at any point using the question box in your GoToWebinar toolbar. There will be plenty of time at the end for us to answer your questions. The presentation will be recorded and made available on our website. We recognize that the international time difference makes it a challenge for some of our global audience to attend these live events. No extra CEUs will be awarded for this presentation. However, we can provide you with a certificate of participation. And now, it's my absolute pleasure to introduce Heather Starmer, a board-certified swallowing specialist and director of head and neck speech and swallowing rehabilitation at the Stanford Cancer Center. She also serves as an associate professor at Stanford, and Heather has helped several members in our community, and we are truly privileged that she has volunteered her time and expertise tonight to share with you the science around swallowing exercises. And with that, I'm going to turn this over to Heather.
Thank you so much, Ed, and thanks to Ed and to Elizabeth for the invitation to be here this evening. So I am going to get my slide sharing. All right.
Perfect. That looks good, Heather. Thanks.
Wonderful. Great. Okay, so welcome everybody. I'm so glad that there are so many people joining this evening. I understand that we have a good connection of clinicians as well as patients and caregivers joining this evening. So it's my pleasure to be here tonight and sharing with you a little bit of information about the basics behind swallowing exercise science and how we as clinicians might optimize the care that we provide to patients with dysphagia. I don't have any disclosures that are relevant to this presentation. And so let's start off with just making sure that we're all sort of on the same page and understanding what we mean when we're talking about exercise. So exercise has been defined as a physical activity that is planned, structured, and repetitive for the purpose of conditioning any part of the body, and there's an intention of improving health and maintaining fitness associated with exercise. And so when we think about rehabilitative programs, oftentimes this is what we're thinking about. We're thinking about events that are planned and structured and repetitive in order to improve function, in this case in our individuals with dysphagia. And one of the really important things that we need to keep in mind when we're thinking about planning these rehabilitative exercise programs is that the exercise must challenge the system beyond the typical activity level. So, for example, if somebody is trying to improve their swallowing, they need to do more than just swallow in order to challenge that system. And so unlike our physical therapy colleagues where they can rely on things like weights and bands, we have to use different types of modalities and different types of interventions in order to access this system that is largely internal and more challenging to access than the arms and legs, for example. So when we think about exercise, we want to think about general principles of exercise that extend regardless of whether we're talking about dysphagia rehabilitation, whether we're talking about physical therapy, or whether we're just talking about general exercise. And so we need to think about the intensity of the activities that we're performing. Again, we need the activities to be at a higher level than typical use in order to push the system and improve the system. So when we're thinking about intensity, we're thinking about things like resistive load, how much force is needed in order to perform the activity. We're looking at things like number of repetitions of the exercise, right? If I do 5 repetitions of something, is that really going to be enough to achieve the physiologic goal that I have? And we're thinking about the duration of exercise over time. So are we talking about doing exercise in 30-second increments, in 2-minute increments, in 10-minute increments? So all of these sort of ingredients feed into the intensity of the exercise or of the therapy protocol. Now, another principle of exercise that's really very important is the principle of specificity, meaning that the activities that we are using to rehabilitate need to closely mirror the activities that we're trying to improve. So for example, if I have somebody just sticking their tongue out and pushing their tongue against a tongue blade, that's quite different from how we use our tongue with swallowing. And so that would be an activity that lacks the specificity of trying to improve actual swallow function or tongue function during swallowing. So we want to make sure that when we're planning our therapy that we're also choosing activities that are specific to what we're trying to improve. And then the last principle that we want to think about is the principle of transference, meaning that we want to use skilled drills that will impact the function that we're looking to impact. So again, we want to make sure that we are choosing an exercise protocol that will impact the actual physiologic impairment that we're looking to improve. And we'll talk about these specifically as we drill down a little bit deeper. So when we're thinking about dysphagia specifically, we can think about 4 different types of exercise. So we can think about exercises that are designed to build strength. We can think about exercises that are built to improve endurance. We can think about flexibility. And then we can think about this concept of skill-based interventions. And so all of these are potential targets that we may think about as rehabilitative professionals to help address the underlying pathophysiology of the individual patient's dysphagia. And it's really critical that we think very hard about what that pathophysiology is. And our treatment goal needs to match our treatment strategy. So we need to make sure that if we have a patient whose underlying pathophysiology is that of weakness, that we're targeting issues around strength. However, if we have somebody whose issues are around mobility and stiffness, building strength is not necessarily going to be an appropriate target. So we want to make sure that we're matching our interventions to our goals. And we'll talk about each of these different sort of areas of rehabilitation individually. So let's start with talking a little bit about strength training. Now, strength training historically has been a big part of the emphasis of many dysphagia rehabilitation programs. And certainly there are situations where strength training is very appropriate for our patients with dysphagia. However, there are also other conditions where strength training maybe isn't as appropriate. So let's talk first about what strength training can accomplish and where we might want to apply this. So when we think about strength training, we can think about the early changes that occur in response to a strength training program, and then we can think about more the long-term or late changes that occur. So early changes, meaning when you first start a strength training protocol, so this could be the first week, 2 weeks, 3 weeks of that training protocol, what we're seeing is changes in performance that are related more to neural activation, meaning that as we are training a particular muscle or group of muscles to perform an activity, and we're working at that from a strength perspective, the nervous system is recognizing that we're asking more of that muscle or muscle group. And so more motor units are being recruited in order to support that activity. So we may get increased speed or increased coordination of those motor units. And so we may see some early functional changes that are not necessarily related to changes in muscle morphology, but rather to the motor unit recruitment that's being utilized. Now, as we get further into that strength training program, and now we're talking something in the ballpark of about 6 weeks into strength training, that's where we start to actually see the morphologic changes to the muscle. So we start to see more strengthening of the muscle, more hypertrophy or enlargement of the muscle. So instead of just seeing functional improvements, we're actually able to see measurable changes in the muscle. And the muscle is able to generate more force generating capacity than it had been prior to the strength training. And then what follows from that is a cortical reorganization where we learn that we need to maintain this sort of strength generation and how we're recruiting those muscle units. And so we get these early changes in terms of just how we're activating the motor units, then we get the changes in the muscle, and then we get the actual cortical change that occurs after that. Now, when we think about strength training, we can sort of tap back into some of our physical therapy colleagues and some of the information out of their research. And so they talk about this concept of the 1 rep max. And what the 1 rep max is it would be the most intense, if we think about resistance, the most intensive resistance level you could use and just barely eke out 1 repetition. So for example, if I was talking about my bicep, maybe I could do 1 bicep curl with a 40-pound weight, but I couldn't possibly do 2. That would be my 1 rep max. Now in swallowing, it's a little bit harder for us to determine a 1 rep max because we don't have great tools necessarily to be able to measure these things. But certainly we do have some tools that may provide that sort of information. So for example, the IOPI, or the Iowa Oral Performance Instrument, is a tool that you can use to measure tongue strength. So there are some tools that we might be able to use to at least gauge an idea of what that 1 rep max might look like. And so what we want to do is we want to have the individual working out somewhere between 60 and 80% of that 1 rep max. And every couple of weeks, we want to increase that, that difficulty level, because if we don't, what happens is we get a plateau effect and we don't get those morphologic changes in the muscle. We have to continually increase the challenge of the strength training. With strength training, it's generally better to perform a smaller number of repetitions at a higher level of resistance. So here we want to try to tap into pushing the system as much as we can in terms of resistance. Now, as I mentioned earlier, we can start to see those morphologic muscle changes in as little as 5 to 6 weeks. So we start to see the change. But unfortunately, the other thing that we can see is atrophy setting in as little as 4 weeks of detraining. So when we are working on a strength training protocol, we do need to also think about maintenance phase at the end of that. And we also want to think about if we go into a period of disuse for one reason or another. So I work with head and neck cancer patients. Many of my patients have surgery, and there may be a disuse period after a surgical intervention. We may get detraining that happens in a very short period of time. So we want to think about that when we're building our strength training protocols. So deconditioning is this concept of muscle atrophy and the deterioration of muscles in response to disuse. So in general, we see this affecting our type 2 muscles more so than our type 1 muscles. And these muscles will atrophy and weaken, and we'll get this shift towards these type 1 fibers that are less capable of producing these sort of ballistic, strong movements. So we can see a little bit more of that sort of lower level sustained muscle ability, but not the really heavy force generation capacity that we need to see, for example, with the tongue base for propelling food through the pharynx. As we get this muscle atrophy, the shift in our muscle types, the nervous system starts to adapt. So it works to our advantage and our disadvantage. If we are not recruiting these muscles, then we get fewer motor units recruited. So it's sort of the opposite of what we get in early strength training. So what we end up with is a functional deficit of slower movements, weaker movements, and less coordinated movements. So this concept of deconditioning is a very important concept when we're thinking about managing individuals with dysphagia, because we don't want them to have slow, weak, discoordinated swallows. So we want to avoid deconditioning wherever possible. So where are some places that we might think about using strength training for dysphagia rehabilitation? So certainly any of our patients who become deconditioned after surgery, as I mentioned before, perhaps they've had a significant acute change in mental status or some sort of prolonged illness where they have just become globally weak. These are individuals for whom, just like the physical therapists want to get in and work on building the strength of their extremities for ambulation, we want to get in and build the strength back from a swallowing perspective. Similarly, our patients who've had a prolonged NPO status, those are individuals for whom strength training may be appropriate, prolonged hospitalization, and certainly there are some neuromuscular conditions where you may get these decompensations, but you have potential for improvement. So we might think about some of our neurological conditions that result in weakness, but where there's a potential for improvement. So post-stroke, for example. So if strength or weakness is the underlying pathophysiology, those are the folks for whom a strength training approach is most appropriate. And so some of the strength-based training things that we may think about as common tools that are in our dysphagia toolbox, one would be the effortful swallow exercise, right? This is an exercise where we are trying to increase the resistance generated during a hard swallow in order to engage more muscle. The IOP is another device-based intervention that we can think about that provides biofeedback to the patient about the generation of strength from a tongue perspective. And then the expiratory muscle strength trainer, or the EMST, is another example of building strength, but instead of building strength from the propulsive swallowing muscles, now we're talking about building strength from expiratory muscles that are important for things like cough and clearance. So these are examples of strength-based exercises that we may use in patients with dysphagia. Now we're going to shift focus a little bit now to talk about endurance. And it's not necessarily that each patient will have only one of these different categories that they need to work on. So we may have someone who needs to work on both strength and endurance. But thinking about eating as being a relatively prolonged act where you need to sustain muscle function over an extended period of time, endurance and stamina is also an important contributor to safe and efficient swallowing. So endurance training may be another area that we want to think about focusing on. So as opposed to strength training, where the physiologic goal is building muscle strength and force generation, the endurance training is geared to improve the mitochondrial mass, the power plant that feeds the muscles that we use for swallowing. So we can build up capillary density, which brings more oxygen to the muscle fibers and feeds these muscles to be able to sustain activities for long periods of time. Endurance training also can increase the storage of glycogen and fat, also as a primary role of feeding the muscles. And so endurance training has a very different physiologic effect than strength training does. Here we're trying to bring more energy to the muscles to sustain activity over time. And so as opposed to strength training, where we want to do a low number of repetitions at a high degree of resistance, with endurance, we want to be performing higher numbers of repetitions at lower levels of resistance. So very different in terms of how we might structure that protocol. So we might be doing 30 to 40 repetitions of an exercise at a lower level of intensity, whereas we might use 10 repetitions of an exercise at a higher level of intensity for strength training. So people who we may think about an endurance training approach would be people who've had, again, some period of relative inactivity, so reduced oral intake or no oral intake for a prolonged period of time. So not only are they weak, they probably also have reduced stamina in terms of eating. Similarly, those individuals who've had prolonged hospitalization or illness. So again, there's probably some overlap in some populations needing both strength and endurance training. But sometimes we have those patients who do fine at the beginning of a meal, but report fatigue or worsening function over the course of the meal or over the course of the day. Those are individuals who we may have to work on building up endurance with. Certainly those individuals with sarcopenia, age-related muscle wasting, we may want to work on endurance for those individuals so that they can build that up over the course of the meal. So an example of an endurance-based activity used frequently in dysphagia therapy are some of our bolus-driven therapies. So these are exercise protocols that are made to involve eating and involving eating over a prolonged period of time during a therapy session. So for example, something like McNeil dysphagia therapy protocol would be considered an endurance-based approach. So as I mentioned, the McNeil Dysphagia Therapy Program, for those who are not familiar with this program, this is an intensive therapy program designed to occur hourly or daily for an hour over about a 3-week period. So it's very intensive. And participants are given homework based on their performance during the treatment sessions. And so again, this is a very structured intervention approach that clinicians who want to use this approach will need to have training. And so you go through the training in order to have certification in using this approach. But this is one very nice bolus-driven therapy that would be a very appropriate treatment approach for somebody working on endurance. And Georgia Malandraki and her colleagues have also published a similar sort of bolus-driven therapy called the Intensive Dysphagia Rehabilitation Approach. And again, this is an intervention that focuses a lot on bolus-driven interventions. And so using a very structured bolus approach, working with the patient to advance that, and focusing a lot on choosing relevant foods to the patient to enhance adherence to the treatment. And this also includes a simplified exercise protocol. So it's not just about swallowing boluses, but also having very targeted swallowing exercises that will support the underlying pathophysiology of the dysphagia. And so instead of giving somebody a list of 10 exercises, you may give them 2 different exercises and then the bolus-driven intervention. So these are things we can think about from an endurance perspective. Now, stretching really targets a very different end of the spectrum. So now we're talking about individuals with restrictive disorders or disorders of tension or spasticity. So very different pathophysiology. The effects of stretching-based interventions are that we are elongating the muscle fibers to their full capacity. So we're really trying to stretch those muscle fibers out. By stretching those out, we're also getting a stretch of the connective tissue and the fascia that's surrounding these muscles. And this allows the collagen fibers to align along that line of tension where that muscle is being stretched. And this minimizes disorganization, which is what we see very commonly in things like scar and fibrosis. We see a lot of disorganization of the collagen fibers. So the goal with stretching is to stretch the muscle, the soft tissue, and to align those collagen fibers in a more organized way. Now, with stretching, it's really important to note that there is this stretch reflex that can occur. And so what will happen if you try to stretch too quickly is you will actually get reactive muscle contraction. And that works against the goal of stretching, which is to elongate the muscle. So we want to make sure that when we're doing stretch-based approaches with our patients, that we're going into that stretch very slowly and that we're holding that stretch for a prolonged period of time. That's going to allow adaptation of the muscles and the soft tissue and decrease signaling of the stretch reflex. So deep breathing into the stretch, prolonging the stretch for an extended period of time. Effective stretching requires holding the stretch for a minimum of 10 seconds and up to 30 or even 60 seconds. And as I mentioned earlier, it's really important that we are breathing normally through that stretching process, bringing oxygen to those muscles and improving our ability to get deeper into the stretch as we're breathing out. We can also think about active stretching or assisted or facilitated stretching, which has been described a lot in terms of like myofascial release and other sorts of manual therapies where the clinician can actually supplement the static stretching that the patient can do on their own. So we might think about this sort of stretch-based intervention or mobility training, I think about it as well, in individuals for whom we have restrictive disorders. So again, I work predominantly with the head and neck cancer population, and many of our patients, whether they've had surgical intervention or whether they've had radiation-based treatments, will develop scarring and fibrosis. And so early mobilization before that scar tissue becomes really ingrained is most likely to be of benefit. We can also use this in individuals with post-surgical scar and fibrosis. Again, we're trying to restore and maintain mobility. In some of our individuals with neurologic disorders where they have more spastic issues, so rather than flaccidity, we have spasticity. We may want to work on stretching rather than strengthening. And certainly we know that there is a subgroup of patients with what's been described as muscle tension dysphagia, where it's really a tension disorder. And in those individuals, again, stretching things out, restoring mobility may improve their swallowing experience. And so range of motion stretches that are really targeted on the muscles that you're trying to restore motion to or maintain motion with, or things like myofascial release and manual-based therapy. Those are some of our tools that are stretch-based. And so finally, we'll sort of move on to this concept of skill-based therapy. And this is becoming increasingly recognized as a very important part of dysphagia rehabilitation, because we know that all swallowing problems are not necessarily related to weakness or reduced endurance or reduced strength. And so in many cases, we want to work on the actual skill of swallowing itself. And so this is really capitalizing on that specificity piece that we talk about when we're talking about exercise science. So our treatment sessions, we want to work on specific areas of their dysphagia. So if we have someone where the speed of movement is a problem, then we may want to work on tasks where we're increasing the speed of motion or perhaps the duration of movement. So again, it gets back to really tapping into what is the pathophysiology, what are the actual underlying issues that we're trying to improve. And what is increasingly understood is that this skill-based therapy actually leads to changes at the cortical level. So it improves that ability to volitionally change and improve the performance of swallowing, not just the muscles we use with swallowing. And ideally, we want to pair these skill-based therapies with some sort of biofeedback. We understand that biofeedback really can optimize patient performance in these sorts of exercise programs. So this may be using something like submental EMG so that the patient is able to see when these events are happening, the speed at which they're happening, and working on timing events, for example. So the patient can use these external devices to really monitor their performance better. Because again, it's much more challenging from a swallowing perspective for individuals to really understand what does it mean to swallow harder, what does it mean to swallow faster. You can see what your arm is doing, but you can't necessarily see what your pharyngeal constrictors are doing. So using this biofeedback can help optimize the patient's performance as well as their performance independently of the clinician. So as I mentioned, we can think about submental EMG biofeedback as one of the biofeedback-driven therapies for skill-based. So we can use this to focus on things like accuracy and effort. So if I want somebody to swallow really strong and really hard, they can see the peak muscle activity associated with that so that they can try to match that better. We can also use it in terms of timing. So if we want to get that swallow started more quickly, we can use that EMG as biofeedback. We can think about respiratory swallow coordination therapy as another skill-based approach. So in some of our patients for whom they don't have good coordination of the respiratory cycle and the swallowing cycle, we can actually teach them how to swallow at more optimal points of the respiratory cycle. So this uses simultaneous nasal cannula feedback or nasal airflow, as well as EMG, so that they can see what's happening in terms of muscle function as well as in terms of their respiratory cycle. And we can teach patients what the normal respiratory swallow pattern is, show them what their disordered pattern looks like, and then have them practice using this EMG and airflow biofeedback with boluses and extending in terms of complexity. We can also think about using fees or biofeedback, endoscopic biofeedback, particularly in our therapy sessions. And this can be really helpful when we're trying to teach compensatory strategies, and we want to make sure that they're really being utilized in the way that we're training. So for example, if I'm working with somebody on a supraglottic swallow technique, they can actually see that they're getting vocal cord closure prior to the swallow. They can see if there's material within the laryngeal vestibule and see how well their cough is able to clear that material out. So biofeedback can be a really helpful tool in teaching some compensatory, particularly complex strategies. And then high resolution manometry is another intervention that's gaining popularity for use in therapeutic applications because it helps to provide that information about pressure and how much pressure is being generated at different points of the swallow. So high resolution manometry can be used for biofeedback, again, similar to EMG, looking at things like accuracy, looking at muscle contraction and effort, and looking at timing parameters. And so this is just an example showing what SEMG may look like, where the patient is able to see what's happening in terms of muscle contraction. You could see these blue bars here. Those could be timing targets that we use with the individual to try to get them initiating the swallow at a particular time. And then there's a relatively new device called the mobility device, which is another EMG unit, and this was designed more for home use. And so whereas the larger units are more helpful in a clinical practice, this is something that a patient can be trained on using with a clinician, take home, and then the clinician can also see what the individual is doing at home. They can see, are they doing their exercises? What is the accuracy level? Are things improving over time or not improving over time? So the mobility is another nice tool that we can use to extend the therapy into the home and still sustain that same sort of biofeedback that the patients benefit so much from. This is just an example of what the SEMG and respiratory tracing might look like. So this is using the Pentax, the K-Pentax swallowing workstation, which unfortunately is not produced anymore. But what you can see on a single screen is you can see airflow and muscle activity simultaneously. And again, you can teach the patient at what point of the respiratory cycle they need to be swallowing. So in conclusion, it's important that we always think about exercise protocols that are going to be focused back specifically on the pathophysiology that we're looking to improve. So our goal should really drive our therapy activities. We really have to understand the pathophysiology in order to make those appropriate goals. If our patient doesn't have weakness, strengthening exercises is not going to help them. So we want to make sure that we're very clearly targeting the things that are most meaningful for the patients. More than likely, the evidence is pointing to a direction that we probably want to include a combination of exercises and skill-based activities. in bolus-driven interventions. So we have more tools in our toolbox than just strength-based exercises. And really, we want to think about integrating these other supportive devices that have been shown to really optimize outcomes. So things like biofeedback, device-driven interventions that patients really tend to sort of connect with, and bolus-driven therapies, particularly focusing on foods that are relevant and meaningful to our patients so that they're really engaged in the interventions. And when we can do all of these things and really structure an appropriate treatment protocol, we're going to be most likely to be successful for our patients. Now, for those of you who are patients or caregivers on the call, particularly if you've had head and neck cancer, or for those of you who are maybe practitioners who work with these patients, I just wanted to invite you all to our 6th annual Head and Neck Cancer Patient Caregiver Symposium. We do this every year in conjunction with Head and Neck Cancer Awareness Month, which is April. So our event is coming up on April 22nd. It is free to attend. We'll have a virtual offering, so it will be live streamed, and the link is at the bottom of the page here. Anybody is welcome to join. You do not need to be a patient of Stanford to join, but it's a wonderful program, and you can go to the link to read more about the different topics that will be discussed. So please join us if you're interested. And at this point, I'm happy to answer any questions that may have arisen.
Heather, thank you. We have over a dozen questions that come in, but I'd like to go off script for a few minutes and just show the resources the foundation has for following exercises.
Wonderful.
I'm going to take this over for a minute. Can you see my screen?
I can see your screen, yes.
So this is the, not sure why that's showing up, but if you go to my resources, you'll see swallowing exercises. And let me get rid of this. And here you'll see 13 different exercises. And if you accept, then that will bring you to a page that has all 13 exercises and a short video of each exercise. You can also print out a template in English and Spanish and check mark for your patient what exercises to perform. So I thought that would be valuable for this group to hear about. And a lot of effort went in to producing this. So with that said, I'm going to stop sharing my screen and get back to the questions.
Great. And I'll mention too, Ed, since you brought that up, We recently created an app specifically for people going through head and neck radiation. It's called the Head and Neck Cancer Virtual Coach, and we just finished our clinical trial on that, and so now it is available free of charge for clinicians and patients to download. It's available both in terms of Apple and Android. So if there are individuals who are interested in using that with their patients, you can check that out. It's HNC Virtual Coach.
Excellent. So, for the questions, when you say 5 to 6 weeks of strength training to see muscle change, what are you assuming for frequency?
Yeah, really good question. The reality is we have very, very limited dose information for dysphagia therapy. So we have to tap a little bit into sort of general exercise science. And generally speaking, they talk about exercising a muscle and then giving that muscle a day off. So probably you're looking at like 3 to 4 times a week doing the specific strength-based training.
Yeah. And for how many weeks?
Usually 5 to 6 weeks is the minimum required period before you start seeing those sort of changes in the actual muscle or increased bulk and strength and force generation.
Okay. Is there a general consensus on what is considered prolonged no food by mouth status?
That's a really good question. I don't think that there's necessarily consensus. I think that we know that generally speaking, disuse of muscles starts to result in atrophy in as little as 2 weeks. So probably if we're thinking about anything 2 weeks or beyond, we have the potential for that atrophy. So I think that's probably the early end of things, but I don't know that there's consensus necessarily on exactly what that definition would be.
Have MDTP results been replicated or published by other researchers other than Prairie and Canopy?
The majority of the research that has been published has been from their group or people who have worked with their group. So yes, it is the majority of it is out of their lab.
Here is a question from someone who had a total mastectomy in 1998. They had been able to swallow okay, but within the past year, food is getting backed up into their throat. Would any of these programs help someone in that position?
It's a really good question. I think what I would encourage is starting off with getting a formal assessment. Given that surgery was so long ago, there's probably something going on that's unrelated to that surgery because that's really quite far off in the past. If there had been radiation therapy, for example, there could be some changes related to radiation, or it could be something that's esophageal and have nothing to do with the head and neck treatment in the past. So I would start with getting a formal evaluation because that would help to guide what kind of treatment may be helpful. But I think certainly there may be things that would help, so I would pursue that, absolutely.
Would Christmas fit into a stretching approach?
Absolutely, absolutely. Trismus is certainly one of the conditions that obviously impacts eating and feeding, not necessarily swallowing itself, but eating and feeding. And absolutely, that would be a stretch-based problem. Strengthening training would not be helpful for improving job mobility.
The questions keep coming in, but are you familiar with using stretching for individuals who have been NPL long-term secondary to neuromuscular disease? And they're thinking about SMA in particular, but any neuromuscular disease would fit the bill.
Sure. I think, again, if we're thinking about, it goes beyond necessarily underlying diagnosis and thinking about what is the underlying issue. So is it a neuromuscular weakness, or is it more spasticity or reduction in mobility? And I think if it's the latter, then a stretching-based approach may be quite appropriate. Now, is there much evidence of this? That I can't answer for sure, because I don't know that literature as well as I know the head and neck. But certainly, I think it would be an appropriate thing to think about in those individuals who have spasticity. And we see that, right? We see our physical therapy colleagues very much working on stretching and mobility in those individuals with neuromuscular diseases with spasticity. So I think it does make sense. Again, I'm not personally familiar with that literature, but I think it's a logical thing to do to match that to the pathophysiology.
And someone with a neuromuscular malady, how does the exercise routine change for them?
So if we're thinking about some neurodegenerative diseases, so if we're thinking about things perhaps like ALS or other neuromuscular diseases where fatigue is an issue, that's certainly something that we have to think about in terms of selecting intervention protocols that are not going to make that situation worse. So I think that again, it sort of gets back at looking at the big picture in terms of diagnosis and the pathophysiology. We don't want to be doing a lot of intensive strength-based training with somebody who fatigues. That's going to work against them, so it's actually not going to be helpful. So I think that we have to keep in mind that sort of the fatigue impact and how that might actually make their swallow more unsafe, perhaps, or less efficient because we're fatiguing that system.
Do you have thoughts on myofascial release?
Yeah, I have been increasingly interested in myofascial release over the past 5 years or so, 5 to 10 years, because again, working with head and neck cancer patients, many of my patients have issues around reduced mobility, scarring, fibrosis, and a big part of preventing dysphagia in that population is maintaining mobility. And so it is definitely something that I have integrated much more into my clinical practice, because again, it's thinking about the pathophysiology and thinking about whereas sometimes there are issues with strength or endurance, really the big thing that we're combating with head and neck patients is scar fibrosis. And so I think myofascial release has really been a really wonderful complement to what I've done earlier in my career. And I use it more and more with my patients in order to restore and maintain mobility.
I feel like I am pelting you with questions, but there's been a lot of interest in what you have had to say. So if you don't mind, I'm going to continue for another 5 minutes. And
that's great.
Okay. Do you have further thoughts on NIMS like amp pair or vinyl stem?
Absolutely. Talk about one of the hot topics in our field. So I think that there is some evidence that suggests if used in the right way with the right patient, it may be of benefit. I think that unfortunately, when initially rolled out, it was sort of promised as a panacea to fix every swallowing problem, and I don't think we have anything that does that in any branch of medicine. So I think there's a lot of controversy around the modality. I think there are things we know. For instance, we know that when we apply electrodes to the anterior neck, we get depression of the hyoid and the larynx, which puts people in a precarious position from an aspiration perspective. So we have to be very thoughtful about how we're using that and making sure that we're maintaining safety. Some people have proposed using it almost as an added resistance. So it does lower things down, which means you'd have to work harder to lift the larynx against that resistance. And so again, that may be an appropriate thing for a patient that you're working on strength-based. We do know in the head and neck population that there has been evidence that it is not beneficial. So again, I think it brings us back to, I sound like a broken record, but it brings us back to pathophysiology. The trials that were done in looking at NMES in head and neck cancer patients largely focused on individuals with fibrosis and restrictive disorders. And so how would we expect a electrical stimulation to improve mobility when that's not what it's supposed to be targeting? So I think that for me in my practice as a head and neck cancer clinician, I do not use it because I don't think that it will be a benefit, and the evidence suggests that it would not be a benefit. Do I think there are probably still some appropriate places to be using that modality? Absolutely. But it needs to be used with care, and it needs to be used with appropriate targeting of the underlying deficits.
Thank you for that. Can you provide some strategies for treatment goals that are aligned with exercise principles?
So like goals that would go into a written report, is that what we're writing treatment goals? Okay.
Yeah, goals for if you can do this in this time period,
right,
that's what we're shooting for.
Right. So, if I was using EMG biofeedback, for example, so if I'm working skill-based on a patient and I want them to swallow within a certain time parameter, so I might write a goal that would say the patient will generate a swallow within the target time period at 80% accuracy over X number of trials. So biofeedback makes sometimes writing those goals a little bit easier. I might use the IOP, for example, and I might say the patient will generate a pressure of 50 kilopascals with an effortful swallow 80% of the time across trials. So again, those biofeedback driven devices can sometimes make it easier because we can have numbers that we can tap into. Otherwise, it might be something like the patient will, swallow X number of bolus trials over a 60-minute session. So maybe we're trying to get in 200 swallows over a 1-hour session. So that could be something that we might use in like a bolus-driven protocol. So those are a couple of examples of things I might use. What I wouldn't use, what is one of my pet peeves, is the goal where somebody will do something without demonstrating signs and symptoms of aspiration. I don't think that's a very good goal because in many of our patients who silently aspirate, that's number one, not a useful goal at all, but also we don't want to be diminishing the signs and symptoms of aspiration if aspiration occurs. So anyway, that's just a pet peeve, but hopefully the other examples were a little bit more helpful.
Last question. and then we'll wrap this up. Are there any patients off the top of your head who are not good candidates for these therapies?
You know, I think that there's not one group of patients that I would say are not appropriate for any of these, but I think it again gets to thinking through what the underlying pathophysiology is. So probably the biggest thing I can think about is those patients who have fatiguing neurogenic conditions. I would not want to be doing intensive strength-based training with them. I think the second part of the question about whether a swallowing problem cannot be successfully treated, I think that we have to do our due diligence in selecting the appropriate intervention for the pathophysiology and hopefully seeing improvement with that. There are certainly conditions where we're not going to see improvement. You know, in neuromuscular degenerative diseases, we want to see maintenance, not improvement. In some of my patients who have late radiation associated dysphagia with cranial neuropathies, I'm not going to undo a cranial neuropathy, but maybe I can make the swallow a little bit safer, a little bit more efficient, or a little bit more compensated. So I wouldn't say there's any group that I would say, oh, this is somebody I wouldn't treat. I just think we have to think about the caveats of the limitations of what we have to offer. And you know, the other piece is thinking about not just the physical motor part of swallowing, but also the psychosocial emotional piece. And sometimes we can't fix the swallow, but we can improve the adaptation to the disorder. So I think that even if we can't fix the actual physical swallow, there's still a lot we can do to help support the person behind the dysphagia.
Well, with that, there's another 2,000 questions that have come in, which to me indicates people have been very engaged in what you have shared tonight. I saw you make this presentation at the Sin City Laryngology conference, and I knew right then that it was going to be very helpful to our community. So I want to thank you again for volunteering your time tonight. That's very generous of you.
It's my pleasure.
And in the next 24 hours, people on the call tonight, webinar tonight, will get an email with some additional resources. If there was a question you had and we didn't get to it, please send that to info@nfosd.com and we'll consolidate those. And if Heather has time to address them, we'll get back to you with answers.
I will be happy.
And so with that, once again, Heather, great job. Thank you, and we appreciate you.
Thank you so much, and thank you for all that you do for our community, Ed. You are an amazing example of advocacy and going above and beyond, so thank you.
You're welcome. I hope our paths cross before too long.
Absolutely.
Okay. Good night.
Take
Good night,
care.
everyone.